Hello, everybody. My name is Garrett Schmidt. I am the managing editor for VBC Exhibit Hall, and I would like to welcome you all to today's webinar hosted by PointRight, which is a net health company, and it's called Real World Strategies for Successful Value-Based Care, or VBP programs, excuse me. And a few items of note before we get started. I'm really excited about this, by the way. Janine has a great presentation for us, but a few items of note before we get started. Everybody is joined today in listen-only mode, so you don't need to worry about muting your microphone. That's been done for you. And the webinar is being recorded, so afterwards, what I'm going to do is send each of you out an email for those of you who have registered and attended. So even if someone wasn't able to make the session today, I'm going to send out a link to where you can review the webinar recording and then also download the slides. So, and I'll remind you about that toward the end. And then lastly, we want to hear from you during the presentation. So we're going to have a time for Q&A towards the end, but you don't have to wait until then to ask your question. So at any time that you have a question that comes up, please ask it with the, you have a little attendee control module there and it says questions, and you can ask it right there. And then we'll get to as many of those as we can during the allotted time today. So without further ado, I'm going to introduce our speaker today, Ms. Janine Savage, and she is the Vice President of Product Management, Analytics, and Post-Acute. So she's going to give you a little more on her background, and I'll hand it over to you at this time. So welcome, Janine.
Great. Thank you so much, Garrett. I'm thrilled to be with you today to talk about something that's kind of near and dear to my heart, and that's value-based purchasing programs. I've been with Net Health for a little over a year. Before that was with PointRight for many years, over 5 years. And I've been working with post-acute providers and payers for over 20 years. So I have a lot of experience in understanding what is important to both providers and payers, and I'm really excited to be sharing some of my insights about how we can partner between payers and providers and many other different types of stakeholders to be successful with value-based purchasing and value-based care. If you're interested, you can take a look at some of my blogs on analytics and value-based care. You can find those on PointRight.com. So today we're going to talk about why value-based care is timely and necessary. I think we can all agree we've been hearing a lot about accountable care recently, and understanding some of the factors that make a VBP program successful. And I'm going to share with you some lessons learned from a successful VBP program, or programs actually. And whether you are a payer, a state Medicaid agency, an ACO, you're somehow responsible for accountable care. And there are concepts that we're going to talk about today that apply in any type of value-based care paradigm. And of course, the goals of accountable care are about driving quality and improving the coordination of care among healthcare providers and payers, and also reducing the cost of care. And we've heard a lot recently from CMS as they've refreshed their innovation strategy about accountable care and health equity. And the path to those really big goals, I believe, is through value-based care. And there are successful models for nursing facilities that already exist. There are states that have implemented successful value-based purchasing programs, and payers, individual payers, who are also offering incentives to payers, or to providers for achieving the goals of accountable care. So we're going to talk specifically about some of the programs that we've been involved with the state of New Mexico. We are the vendor of choice for analytics, and we partner with them on 2 value-based care programs in the state. So as we go through kind of what the best practices are for value-based care programs, I'm going to share with you some lessons learned from those programs. It's interesting that these concepts are not new, and actually the Institute for Healthcare Improvement launched the Triple Aim way back in 2007. And that's very consistent. The triple aim is the patient experience of care, better population health, and decreasing per capita cost of healthcare. And these are very consistent with the strategy that CMS has announced and the goals that most payers have for accountable care today. So what I'm hoping is that we can actually have some great examples of the triple aim in real life as a result of getting more aligned in these three areas. Let's first talk about engaging stakeholders. In order to be successful with value-based care, the stakeholders really need to be in alignment. And we'll talk about what that means and what it takes to do that. First of all, who are the stakeholders? Well, certainly providers of care, the ones that will be directly receiving incentives and penalties, are key stakeholders. The payers, obviously, and patients. Sometimes the focus is so much on the providers and the payers that we kind of tend to minimize the effect that these kinds of programs have on individual patients, populations of patients, and patients across the healthcare continuum. And certainly state agencies, when they are involved in these kinds of programs because of the involvement of Medicaid funds, are key stakeholders as well. So in the New Mexico program, there are two programs in New Mexico. The first one is called the VBP program. And in that program, there was a four-pronged approach of stakeholders consisting of a community advisory board, so individuals from the provider community, the managed care organizations that administer Medicaid and in the state as part of a VBP work group, a provider advisory group, and Project ECHO was also involved and still is involved today, I should say. The next thing you really need to establish is what are the goals and objectives of the VBP program. These could be specific clinical and quality outcomes that you know that you want to change. It could be related to the incidence of adverse events, may be very likely related to utilization outcomes, things like ED use, hospitalization, healthcare utilization across the continuum. Maybe you want to see changes in process happen. Maybe you want to encourage the adoption of new technologies. Certainly, over the last 2 years, we've seen the rise of telehealth and telemedicine. Other outcomes or results that you may want to see based on your population of patients or members, and the things that you think will help move the needle in terms of those three big goals of accountable care. In New Mexico, there were very specific project goals to improve quality of care, specifically reduce avoidable hospitalization, and a very broad goal of optimizing health for those New Mexico Medicaid members receiving services and nursing facilities. It can really help align all the stakeholders if you identify what the goals and objectives are. And the way that you achieve that success is through partnership and collaboration. And how you get there is by leveraging your data and analytics, by driving communication among stakeholders, and really having, I would say, an unprecedented degree of transparency. It really helps to have everyone looking at the same metrics, the same outcomes, and driving toward the same goal. And this is ultimately what helps drive improved patient care and better patient outcomes. And then, accordingly, outcomes among populations and facilities. And the program design and the deliverables that everyone will have access to really need to be aligned accordingly. Oops, I'm sorry, skipped ahead. Some of the key factors that we considered in the New Mexico program was that we wanted to have access to the same patient level analytics and the P4P dashboard, excuse me, for both the providers and the payers. A lot of P words here. We knew that it was important to drive that communication and transparency by having regular work group meetings. And as the data analytics vendor, we became an equal partner in this process, which was really, really key to helping us facilitate the goals of the program and this kind of transparency and providing the opportunities for the collaboration and communication. One of the things that is most essential to consider in a VBP program is the right mix of incentives and penalties. The old carrot and stick. And Dr. Scrace, the Cabinet Secretary for Health and Human Services in New Mexico, really said it best. Value-based payments are a tremendous opportunity to better care for the state's most vulnerable residents. But we needed all parties working together using the right incentives and penalties to transform the payment system and create a system that would be both effective and long-lasting. Couldn't say it better. It really is important to consider both the incentives you're providing and the penalties, because ultimately every party is thinking about what's in this for me and how can I benefit from this. Specifically for the ACOs and the payers in value-based care, better member-level outcomes lead to better population outcomes, and that leads to better facility performance specific to nursing facilities. We also see the opposite direction when we look at our outcomes. So facilities that perform better tend to manage populations better, even in different areas where maybe they're still evolving. And that means that individual patients, your members, will get better care. And this all results in better utilization outcomes across the continuum, less ED use, less hospitalization, more appropriate care pathways being planned for your members, and overall, a lower total cost of care. And specifically, we can impact the cost of post-acute care. For the MCOs, a big benefit of the New Mexico program was getting access to member and facility level information about quality and clinical care that they wouldn't have otherwise had. Now we'll talk about effective design of a program, how we measure quality and payment structure. So the major components of a VBP quality program include some mechanism for the funding of the program. Obviously, you have to figure out where the funds are going to come from. A measurement of quality. How is quality going to actually be measured? How are you going to assess performance of the facilities? And how are you going to link performance to payment? So we'll consider some options for each one of these. Funding mechanisms can be varied. Payers certainly could fund, where allowed, could fund their own value-based care programs. Sometimes states allocate funds specifically through their budget process. In one of the VBP programs in New Mexico, there is a provider surcharge or a tax that funds the program, partially funds the program. And in the case of state Medicaid funds, often there are federal matching funds involved. So depending on the funding mechanisms, also the requirements of reporting and approvals are going to vary. In terms of quality measurement, it's really important to consider some key factors in selecting measures. There are different types of quality measures and metrics. We think about different types of structure measures, process measures, how you do something, outcome measures, what the results are of a process, and of course, resource utilization. We have to also consider patient populations. Are we focused on a short stay, more skilled population, or are we focused on a long stay population, chronic care, those who might be appropriate for end of life care if they're long stay residents in nursing facilities? and what are the goals of care, and what are the goals of the population, and what are the appropriate and relevant measures that relate to those populations. What are the state and provider priorities? Very often, providers and provider organizations have already identified areas where they would like to improve quality performance and maybe working on those things. Can we align and can we leverage the work that's already been done and build on that to be more successful? What's the current and historical performance of measures that are being considered? We might calculate a baseline. We may look at historical performance over the last 2 or 3 years. What is the likelihood that we'll be able to improve performance in a certain area? And of course, we want to select measures that are valid and reliable from a sound statistical standpoint. When we think about calculation methodology, we can consider measures that are either in real time, calculating them based on data, or measures that have already been calculated and possibly reported through other means. If we're going to calculate measures, are the specifications available? What data is needed to calculate them? So these are some of the questions that have to be answered when we're considering measure selection. In terms of assessing performance on specific measures and in a quality program as a whole, there are many, many different ways that this can be structured. We'll think about assessing baselines. Do we want to incentivize for achievement? Do we want to incentivize for improvement? Do we want to do some sort of a tiered system? Do we want to rank facilities' performance? What are the appropriate benchmarks? Are we going to measure rates? Are we going to measure ranges? So there are a lot of different things to be considered, and someone who has experience in this area can kind of help you through that process and give you options, and even do what-if scenario modeling to show the impact and what payment and performance might look like based on different options that are selected. Here's an example of a fairly straightforward program based on 4 measures and based on cut points. There are, of each measure, there are points assigned that are then added up to do some sort of a tiering system. So an achievement of so many points puts the facility into a tier, and you can even consider a percentage of payment that changes over time. You may want to give facilities a little bit more payment in the early stages of a VBP program, and then gradually decrease that as facilities become more used to the program, as they implement more best practices. This is really the raising of the bar over time. And there are lots of different ways. This is just one example that a quality achievement structure might look. And in terms of linking performance to payment, we talk about the mechanics of payment. Here's again just an example. There are many, many ways to do this. In a program that we're involved with, there is a foundational payment. So this is to encourage facilities to participate in the program and to offset any costs, such as for data submission. And this is could be a set amount or maybe adjusted for quality performance as well. Then there's a main quality performance, so the payment. So this is based on the quality measure performance, and this is calculated based on how the facility does across the measures that are counted. And then because not every facility is going to get the maximum amount of payment in that step, there is a residual fund amount available. So then you need to think about, okay, how do I want to redistribute or reallocate the funds that remain? Maybe I want to just reallocate that based on the original percentage, or maybe I want to measure something different for that residual funds payment. And then sometimes you could carve out another amount to do some sort of a secondary payment, maybe even on a different frequency. And this may be for encouraging participation in certain programs or adopting certain behaviors, maybe a certain number of telehealth or telemedicine visits, for example. This is just one example of, some of the ways that you could structure the payment and link that to quality performance. And there are many, many options available. Then there's some other things that should be considered, like how are you going to determine if a facility is eligible to participate? How do they actually enroll in the program? What are the data submission requirements? Are there any additional contractual requirements that you will need to consider in your relationship with the provider? Maybe there's a transition period where there's a ramp up or different requirements early in the program, and then more stringent requirements later in the program. And what is the time frame for each performance period? I'm going to show you an example of something that's been very successful in terms of performance period and timely payment. In New Mexico, we did have an initial ramp-up period with pay for reporting, and then later pay for performance was introduced. And that was very successful because it gave the facilities a chance to get used to the program, to do some foundational work to be most successful for improving their quality outcomes. And there's a 12-month performance period with quarterly outcomes measurement and payment. And I'll show you kind of what that looks like. So each quarter, we refer to, it's a calendar quarter in this particular program. We refer to the data collection period. And so we're collecting data and calculating quality measures actually in real time and giving them visibility to how they're doing in the current performance period. And then they have 30 days to complete their data submission, to wrap up any assessments that are outstanding. And then at the end of that period, the quarter is locked, and then payment is calculated, and that information is final. And up until that point, payment calculations are preliminary. So they do have visibility into how it's, what their forecasted payments are. And 30 days after the close of a quarter, which is very quickly, they know exactly what they're going to be paid for that quarter. And they get payment very shortly thereafter. The facilities love this because it's so timely. In other state programs we've seen, and other types of VBP programs payers are offering, there may be a 12-month performance period, and they may not get their payment until many months after the 12 months is over. Sometimes they don't have visibility into their outcomes or how they're forecasted to get payment while the program is actually in progress. And those things are all demotivators for a provider to actually, and it actually limits their ability to actually improve quality at the patient or member level. So it's very important to consider how can we best make timely payment and give them visibility into their outcomes, not after the fact. So now we'll talk about the data and analytics in these programs and what some of the key factors are in those areas. In terms of analytics for measure selection, it's absolutely critical that you have someone working with you who can evaluate measures and the data sets that are involved. We recommend a broad set of measures that creates an incentive to perform well across the board rather than focusing narrowly on a very small number of areas. That kind of helps avoid the teaching to the test paradigm. We have to think about handling of bias. That bias is a real thing in analytics, and you need to be able to identify that and account for that. Accounting for clustering, sometimes variable sample sizes and location can have a big impact on outcomes for individual facilities, and then there's also an impact across the group that you're measuring. We look at data analysis across time to make sure that we don't have, such as we just did in the last 2 years, periods of time with variations that may be explained by certain events. And if that is the case, then how do we account for that going forward? And that random versus systematic variation, such as the impact of COVID-19 on quality measures, needs to be evaluated. We like to encourage performance metrics that incorporate the best possible information for the comparison of outcomes at a facility level that would be expected if the same patients were to receive care that matched the comparative norm. And so that's a long way to say adjusting for differences among facilities, and sometimes we will risk adjust specific measures in order to account for differences in the patient population from facility to facility, as well as facility differences. And imputation rules. So what will you do, for example, if a facility doesn't have enough in the numerator or in the denominator of a measure in order to calculate a valid measure? What will you do instead? And there are different things that you can do, such as perhaps imputing or substituting an average rate or a median rate for that facility, or excluding that measure from the mix, depending on what your methodology is. So in order to consider these, you really have to be working with someone who has core competencies in analytics and data science and can really consider these areas thoroughly. In terms of data collection, there are different standardized data sets in nursing facilities. There are really just 2 standardized data sets. In terms of clinical data set, the MDS assessment is the only completely standardized data set. And then the claims, the nursing facilities file UB04s or 837Is, and that's a standardized data set as well. EHR data in long-term and post-acute care facilities is not standardized like it is in acute care or primary care. And that's because nursing facilities were left out of meaningful use all those years ago and are still left out of those CMS incentives that have evolved from that. And so we can't rely on an EHR data set to be standardized among all facilities. And of course, different facilities use different electronic health records. But we do have a good clinical standardized data set, and that's the MDS. There are CMS publicly reported measures, and those have limitations, but may be part of programs. There are standards for data exchange that are emerging. There are some, lagging behind performance in nursing facilities in terms of data exchange and how robust or mature that is in long-term and post-acute care. So we have to think about that and be realistic about what the possibilities are for data exchange. In New Mexico, one of the requirements was to minimize the data collection and submission burden on the facilities. The facilities are, of course, as we know, very taxed today, and any additional burden is really going to be a negative for them. So we needed to ensure that that was minimized and that whatever we asked them to do would fit into their existing workflow, and ensuring that the data source would allow for real-time actions to be taken by the facilities, because it was understood that that was essential for driving quality improvement as quickly as possible. We need to consider, how are the analytics going to be delivered within the program? Obviously, they need to be relevant to the provider and the patients that they're caring for. They need to be timely, and they need to be actionable, because that's how the providers will achieve both their payment incentive targets and also what we really care about, executing data-driven performance improvement. They need to fit easily into the provider's existing workflows. Anything additional that we ask them to do is going to be additional burden, so that workflow is hugely important. And the insights that we give them have to be simple to understand. They can't spend a lot of time and resources trying to understand or interpret what the information is telling them. In New Mexico, the requirement was that we would show actual facility performance in their past time periods, that we would forecast their performance for the current time period in progress as it was progressing, and that we would give them real-time information at the patient level. And this would be delivered in a highly intuitive user experience in a dashboard format with export capabilities. And the export capabilities are very important for those organizations with multiple facilities to be able to get insight into multiple facilities really in one click, and also for the managed care organizations so that they could export the information to actually review and process that information to issue payments. And I'll show you some examples of good, intuitive, high visualization design that really facilitates the insights into the information that we're presenting and really make things much more actionable, which of course is the most efficient path to quality improvement. This is an example of a program that is showing the payment information. So here I can see the total payment that I've gotten. There's a little lock icon here, which means this performance period is over. So this is actual payment for the period I've selected and how that payment is being calculated. It's showing which MCOs are responsible to pay me what parts of how much payment, and how many bed days, because that's used as a multiplier in this particular program, are attributed to each of them. I can get more involved or more detailed information for each quarter of the payment period. And here you can see I even have target setting capabilities. So I can see where I'm performing compared to where I need to perform in order to improve. And I can see on each of 4 measures here, as I have as an example, how I'm doing on each of the measures and how that's impacting my overall performance. And I have drill down capabilities to see more detailed information. How am I doing on my quality measures that are being measured in the program? How am I doing over time? Are the things that I'm doing to address certain quality measures, are they effective? Is it having an impact on the rate overall? And I can even drill in and see who are the actual patients or residents involved in each quality measure. And in order to achieve a different tier, which equates to, different payment, how many residents do I need to not trigger that measure in order to move the needle? And who are the residents who are currently triggering this measure? I could also look at the measures of the residents who are not triggering the measure. If I have a measure such as immunization, they're the ones that I would want to focus on, those residents who are not getting an immunization, right? So then I can really go into those residents and plan individualized care and make a difference so that I can either turn it around or prevent complications from occurring. We need to think about how we're going to implement the program in order to be most successful, and how we're going to evaluate the success of the program and make changes going forward. So we worked with New Mexico on a gold standard implementation process for both of their programs, provided education and training on the programs, and also best practices related to the measures that are in the programs. You might want to do things like holding open office hours with experts so that providers can ask questions and can get the advice of experts on their individual outcomes so that they can continue their journey of quality improvement. And one of the things that we found is very, very important is having program information and frequently asked questions available at the user's fingertips. While they're using the information that we're giving them, that they can, figure out the answers to their questions on their own. And we anticipated the questions that would be frequently asked, and then we continued to collect the questions that were asked and add those in the application as well. We had the requirement to help providers not just understand how they were performing, but to help them achieve their payment incentive targets in New Mexico, and how we could help them execute data-driven performance improvement in the quality measures that were of interest. And then additionally, we work with the work group and the stakeholders to help them understand their outcomes and determine their future program targets, and how that we might change things to that end. And we also work with them to provide the information that they need to meet CMS approval requirements. That ongoing evaluation from an analytics point of view is extremely important. So we run all kinds of tests to evaluate performance, to determine if changes in things like the median and the average rate are actually statistically significant. We work with them to determine what may have impacted the outcomes at individual facilities and across facilities in the state. We look at who the outliers are. We create the baselines that are needed for CMS reporting. We create new benchmarks going forward, and we provide those what-if scenarios that I spoke about earlier so that they can evaluate what will happen if, for example, a payment structure item driver is changed, or if maybe we switch out one measure for another, or change the number of points, the weighting, if you will, of a measure and how it's calculated, and what will happen with the distribution of payment to facilities. So again, we help them determine their future program targets and the requirements that will be included in the program, and provide the information for them to fulfill their CMS approval requirements. So to kind of wrap up, I guess I would say that there is information out there about those who have blazed this trail and who have been early adopters and early implementers of value-based purchasing programs in skilled nursing facilities. We have a case study available about New Mexico, and we will be making that accessible to you. It's also really, really important that it's to understand that it's about more than data aggregation or data management, and that in order to be successful in a value-based purchasing program, we really need to choose the right partner who has very deep knowledge and industry subject matter expertise, who understands both the providers and the payer needs. And I can't stress enough how important it is to have really sound analytics and data science core competencies. And lastly, we are hearing so much today about health information technology and things that sound so interesting and promising. But proven success at scale is really what you need in order to ensure success with value-based purchasing. So leverage the resources that are out there and the people who have that kind of deep and wide knowledge, and that's the best path to starting down a value-based care journey. And now I would like to open it up for questions.
Okay, well, great. Well, this was there's a lot here, and obviously there's a lot of questions to be had, and So if you guys have questions, please go ahead and submit them now. We do have some already in. I do see a couple hands raised. So we're not actually doing the calling on the hands, but if you want to submit a question, we'll go ahead and get to that. Starting in no particular order, first question is, how many measures should be included in a VBP program?
That's a great question. I'm going to give sort of a non-committal answer. It depends. And, we start with what are the goals of the program? And what are the measures that we could consider in order to achieve the goals of the program? And what are the data sources available? And, we kind of go down the checklist when we're determining the number of measures. In general, I would say you don't want to have too many measures. We've seen some programs that have so many measures, it's really almost impossible for facilities to decide which measures to focus on. And if there are too many measures and the way that performance is linked to payment is too spread out, then it's hard for them to move the needle and actually see improvement and get motivated by incentives. So a manageable number of measures, probably less than 10, is ideal. But having too few measures can have that kind of teaching to the test constraint, right? Where we get so focused on individual measures, we're not kind of seeing the big picture. So it's important to have a balanced approach, but it really depends on what your goal, your clear objectives are.
Okay, great. And next question is kind of related. What are some of the specific measures for a post-acute care VBP contract?
Okay. So we encourage, when we work with organizations, we encourage them to think about clinical measures and utilization measures and having a balance. Utilization measures are the ones that everybody thinks of right away, right? Hospitalization for a long stay population in nursing facilities, readmission for your short stay population in nursing facilities, also maybe length of stay, right? We encourage them to also think beyond the utilization and look at what are the clinical drivers of those outcomes. Because if you start to improve the clinical drivers of those outcomes, then you will see an impact on the utilization measures as well. So we talk about those things when we work with organizations in developing a value-based purchasing program. And really, one of the things that we do is evaluate their data on the utilization outcomes and also their clinical data. And so we can advise them specifically on what might be the clinical drivers of those outcomes.
Okay, great. This next question sort of goes along with it. What are some of the most underrated or underutilized metrics?
Well, it's related to the answer I just gave, I think. And that's, sometimes there are clinical drivers of utilization outcomes that you would not expect or immediately identify, right? So for example, I'll give you an example. For short stay readmission, we always think about things like sepsis, right? And other types of infections. But in our research, what we found in nursing facilities, that there are some little known drivers of readmission. Things like unmanaged pain, for example. Things like RN staffing levels. So those are things that we might want to look at in terms of framing outcomes targets and incentives so that the actual root causes of the utilization outcome get addressed and improved.
Oh, well, yeah, that's good to consider. Okay, next question. What should clinicians do if a result or a recommendation from the VBC data set or report seems incorrect or unclear?
Seems incorrect or unclear. So sometimes providers will look at a result or an outcome, and I think maybe this is what the question is getting at. and they question it, right? And they don't believe it. So what I think is important is to give them visibility to exactly the way the measures are being calculated. And that's one of the reasons that the patient level information is so important. So if I have, a measure and I have a rate of, X%, I should be able to see all of the residents or patients or members, if you're a payer, who are contributing to the numerator, or the calculation of that measure. And that's what helps them understand why maybe the rate is what it is. And in giving them visibility to exactly how the measures are being calculated helps kind of debunk that. And occasionally, I mean, right, software, there are bugs. Occasionally, there may be something that isn't calculating correctly, or something that is sort of what we call a corner case, right? And sometimes that happens in the data sets. And so we can identify that very easily by seeing, who is actually being counted in the quality measure outcome. I hope that kind of answers the question.
No, yeah, I think that makes sense. Okay, and we only have time for one more question. So the last question here is, how do you get the SNFs on board with submitting data? My understanding is that most of them are not as advanced with interoperability from a technical standpoint.
That's a great observation. That's true. I think in general, it is true that from an interoperability standpoint, many facilities are not as far along as other types of providers. I think that's why it's really important to have realistic data submission requirements, and to work with data that they're already using in submitting. That's one of the reasons, honestly, that we used the MDS clinical data. Not only is it a very standard, rich data set and kind of underrated as a data set, but you can also calculate utilization outcomes from it, and it's in a standard format. It's in an XML file format that is easy to transfer. Right? So there was no building of special interfaces or anything like that. So I think being realistic about the data set and the realistic limitations that some facilities have for data submission. You might also consider things like, incorporating some of the publicly reported measures by CMS as part of the program, because those are easily accessible. So there are different things that you can do in order to overcome that challenge.
Okay, well, good. Well, as I said, there's a lot here, and I'm sure there are a lot more questions to be asked. And if you have a question, again, please ask it as we wrap up here. We'll make sure to get to you via email afterwards. But at this time, we're going to go ahead and wrap up. And I want to thank you, Janine. This was a great presentation, and just so much there. In conclusion, I wanted to invite you all to come and check out the PointRight booth. It's a virtual booth at the vbcexhibithall.com. And you can see it here. And if you go there, you can interact with their team and get some more information about some of their solutions and what they're doing. So highly recommend that you go and check that out at vbcexhibithall.com. And then lastly, we're going to be sending out again, the link to the recording afterwards. So you'll have that, so you can download that and get in touch with them, and there'll be some more information there, as well as a place where you can get the slides. But if you have any questions for the PointRight team, please reach out. Allison Hessian's email is here, and so you can reach out to her directly, or you can reach out to me as well, and be happy to put you in touch with the team. So thank you all again for attending today. This is a great presentation. Please stay healthy and have a wonderful rest of your days.
Thanks so much.
Bye-bye now.
Bye.